Go ahead and call our prevention subcommittee meeting to order. Ms. Rodriguez, do you mind, can you hear me okay? My
Yep, we can hear you.
everything is lagged on my end. Thank you. Do you mind calling the the order for us, please?
Senator Joniate, Jessica Johnson,
Present.
Debbie Nadler,
Present.
Angela Nichols,
Present.
Eric Schoen,
I'm here.
and Senator Severs Ganser. All right, Chair, we do have a quorum.
Wonderful. Thank you all so much for being here today. We'll move on to agenda item number 2, which is public comment.
I understand there's been some updates to open meeting law, so I now am going to read this full slide. So public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241020. If you're dialing in from a telephone, you can dial 1-253-205-0468. And then when prompted, enter the meeting ID 825-0031-7472. And please press *9 so the host can prompt you to unmute. I'm looking at my participants and I'm not seeing any hands raised. I do see a G Goodlander with their mute button off. Did you wish to provide? Okay, that's muted now. Chair, I'm not seeing any indication that anybody wants to provide public comment at this time.
Okay, thank you. With that, we will move on to agenda item number 3, which is a review and approve of the minutes from our June 20th prevention subcommittee meeting. It feels like that was just yesterday. I'll give folks a moment to review, and once review, I'll entertain a motion for approval of the June 20th subcommittee minutes.
Jessica, for the record, this is Eric. I would move that we approve the minutes, and I'll wait for a second, then I'll make some comments.
All right, there's a motion on the floor. Any discussion?
We need to have a second, I think.
Okay.
This is Debbie Nadler for the record. I'll second that motion.
All right, thank you, Debbie. Any discussion on the minutes?
Yeah, thank you, Jessica, or Chair Johnson. Very quickly, I just wanted to, I have served on dozens of boards, too many to count. And I got to tell you, these minutes are some of the best I've ever seen. And I think that's you, Emma. I think you've said you're the one who does them. No?
It's actually my colleague, Margaret. She's here right now. She's off camera, but she does them for prevention and Laura Hale does them for the full meetings. Thank you.
So, Margaret,
Thank
please
you.
take a bow. This is a type of context that I've always wished all board meetings would have. And it is terribly, it doesn't happen near often enough. And you do a good job of capturing, I think, both the content and sort of the tone of the conversation. So if somebody who hadn't been at the meetings really wanted to follow the decision-making process, they could do so. So just thank you and kudos to you.
Thank you. I really appreciate that.
Wonderful. All in favor of approval of the minutes, say aye.
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 Any abstentions, opposed? Any abstentions? All right. We've approved the minutes from our.
So Chair Johnson, so here's the fun part. Margaret now has to include that little bit about being appreciated in the minute. So it'll be interesting to see what she writes.
I was just deciding whether or not that's
Please include Margaret.
I will include. Thank you.
All right, wonderful. We'll next move on. We have two presentations, so we'll move on to agenda item number 4. This is a presentation on adolescent peer support from Ari Chelly, who is with There Is No Hero and Heroine. At a previous meeting, Ms. Nadler, who's on our committee, recommended a presentation from There Is No Hero and Heroine. So I will turn it over to Ari Chelly, and if Joe Engel is on the line as well to give their presentation.
Hi,
Yeah,
thank
hi
you.
guys. I am on the line. I just be available for questions. I'm going to be on mute. Ari's going to do the presentation.
Thank you.
Thank you so much for giving us a chance to present on a topic that's very important to us and a population that we love very much. So I just wanted to start by the disclosures. So it would be next slide. Yeah, thank you. So we do receive minor prevention grants from PACT, approximately 5,000 left in funding. SURG, we use their funding for peer support, community engagement, early screening, access, treatment, data collection. That's also ending September 30th, and we have approximately 50K left in that fund. The purpose for the recommendation seeking to expand services statewide during this presentation. Okay, next slide. Oh, thank you. So Alternative Peer Group is a community-based peer-led support program. It's designed to help young people recover from substance abuse and maintain long-term sobriety. It offers supportive networks for peers who understand the challenges of addiction and provide engagement, mentorship, and guidance. Some of the best practices of the APG interventions are peer support and mentoring. APG emphasizes the importance of peer support and mentoring. Peers have successful outcomes when substance abuse have role models to serve as guidance, to give guidance and empathy and accountability to their peers in the program. And something I wanted to say on this note, we actually have 2 staff members who were recipients of this program, and now they're employees here providing peer services to other youth, and in some cases have more time in recovery than other staff members. So we really highly value support and mentorship. Next slide. Holistic approach. So this is very important. We like to address the physical, emotional, social, and spiritual aspects of the individual's lives. This provides access to a variety of services, including counseling, life skills development, education support, recreational activities to support the individual. It's a little bit challenging with youth because they're kind of in that formative state. And so that using really interrupts that process. And so trying to kind of meet them in this more holistic approach is best practices for them. And then of course, family involvement it's so crucial. It's very difficult to have an adolescent who is in a family system where they could have family members who are using, maybe elder siblings or maybe even their parents themselves, or lack of resources, housing, and we help. We bring the families in and offer services to the families as well. Within appropriate range, we offer access to state programs. We have a state employee that's here on staff. So if they need any kind of vocational training, we also offer that to the peers as well. And then positive peer culture. We really promote the development of positive peer culture. So this is where individuals can recover and interact with one another and share similar experiences. It's so important for adolescents to have that connection with other adolescents because that's where they are developmentally. And so this really meets them at that appropriate developmental milestone. So it's very difficult, just like with setting people back into a family system with using, it's very difficult to send an adolescent back into a friend system where their friends are also using. And so this model allows them to have access to other youth similar in age who are trying to overcome the same thing. So it ends up being just this really great support system. Next slide, please. Thank you. And long-term support. I was just reading an article earlier today talking about how substance use on an adolescent, the effects they're finding it to be 5 times as long on the brain as it is with adults. And so adolescents need long-term recovery support at an unprecedented rate than adults. And so we have at our program, about 30% of our adolescents are sustained engaged in programming for over a year. So they keep coming, and it's so important to kind of foster that bond. Next slide. Thank you. So some of the issues we identify with adolescents is that peer influence, which we kind of talked about a little bit earlier, that lack of supportive communities. It's really difficult because when an adolescent comes in here, they don't have a lot of support systems. They don't have like a work support system, or they don't have maybe a church support system, because they haven't have enough lived experiences to kind of find groups that they feel support them. And so it's really important to kind of connect people to different social supports at that age, and holistic approaches in recovery. Also, substance abuse really stems from a lot of underlying issues such as trauma and mental health. And one thing that I really, really respect about being here is that we always have clinical staff on site that can offer any kind of crisis intervention or trauma treatment. And also spiritual, I think it's important to kind of to address the spiritual aspects. Or the spiritual deficiency that happens to somebody as they're using it, kind of is like a downward spiral. Another issue is the lack of long-term support that's in the community. Next slide. Sorry, thank you. So again, there's really not any long-term groups to help adolescents. We recently went to an adolescent or an APG conference, this models conference, and most of these agencies are doing this group once a week, and we're doing it Monday through Saturday. So even people who use this model are such a limited resource still for the individuals receiving it. And here we're doing it like no one else is doing it, because we're offering it like a drop-in clinic where you can come in and get the service at any time. So it's so important to fill that issue and that gap. Again, family dynamics, substance abuse really strains the relationship, and kids tend to get scapegoated in the family when they are, their using is obviously problematic, but they didn't necessarily become that way in a vacuum. And so there are other people that have contributed to the dysfunction in the family unit. And so it's really, really important to kind of look at the person in their environment, in their family system. And then youth-specific treatment and interventions. It's interesting because almost all the treatment modalities people graduate from, and we really understand that, especially for adolescents, this is a lifestyle. Recovery is a lifestyle, and you're going to need these supportive services for an extended period of time. So this is more tailored towards those developmental stages that young people are facing. And that, of course, increases the efficacy of the programming. Next slide. So by addressing these issues, APG really creates a supportive and empowering, sustainable recovery environment for adolescents that they might not be receiving in their home or in their school and with their friend group. So this helps to build resiliency and achieve long-term sobriety. Next slide, please. Some of the special populations within the adolescent group that we have, because I think this is important to note, our ages are 12 to 24. And some of our youth demographic are LGBTQ members, youth who are in the child welfare system. We have youth that are in court programming. We have pregnant youth. We have minorities who are disproportionately affected by addiction in our community. And then we have the underinsured or non-insured that we also help too. So it's more than just saying from 12 to 24, they're the most vulnerable 12 to 24-year-olds. So I just wanted to make that point be known. Next slide, please. So APG, evidence-based model, it's comprehensive adolescent recovery support model, and engages on that peer level with pro-social activities. And like I said before, it's developmentally appropriate for recovery. Next slide, please. Positive psychosocial outcomes. It really is important to build self-esteem. When kids come here, they often tell me that they're bad kids. And it just breaks my heart, because their self-esteem is so low. Like I said, they were scapegoated in that family system, or, in the court system, or in the family welfare system for so long. And this peer support is like, I see you, I acknowledge what you're going through, and we're going to help you find the best path for yourself to feel some kind of self-respect and dignity and worth. So it's very, very empowering, and they feel better being around other kids that have been through that similar situation. And then enhanced relapse skills. This is so important. We do harm reduction here. All of our kids know how to administer Narcan. They all know how to test for fentanyl poisoning. There's no shame when we have kids who show up here loaded, and they're scared. And it's like a bittersweet thing. We feel so blessed that they feel safe enough to come to us, but of course we're sad that this is, the choices that they make. And then so they're using and then know to try to go somewhere safe and try to get the resources that they can get to be back on track again. So really, really powerful. And eventually they keep coming, like I said, with sustained engagement, and they're able to really get that long-term recovery in the way they define it. Next slide. Thank you. So again, this is, evidence-based, effective in supporting substance abuse treatment for adolescents. It improves treatment engagement. I think a lot of times when we think about adolescents who are using, we don't realize that there's play therapy that's super important aspect. I think with teenagers, we kind of think that they have this like chip on their shoulder and they don't want to engage in the same way other youth do, and that's just not true. So we try to really foster having these positive experiences so they can get that that good feeling, that sense of fun, authentic fun and connection without using substances. And then reduce substance use, like I said. This overall improves sobriety outcomes, and this peer-led support is kind of like a disarming thing for adolescents because there's no legitimate power. It's not, I'm the boss and I'm going to tell you what to do. It's like, well, what do you want to do with your life, and how does substance abuse take you away from that or get you closer to that? And next slide, please. And then cost effective. It's a lot. It's very cost effective to have these kind of sustained engagement programming than it is to keep sending somebody 30 days to inpatient. And then when they leave, services don't have that community support that they need. Next slide. Thank you. So the gaps are access to specialized youth and treatment. There's an absolute shortage when it comes to dealing with this population, not just with facilities, but also even with clinicians. Very scared to deal with co-occurring with substance abuse. A lot of clinicians, even if they have dual licensure, and even treatment centers as well for adolescents, it becomes a very scary, because the population is so vulnerable. People just rather not. So it's really important to increase access to the specialized youth treatment services. We always treat adolescents the same way we treat adults: 30 days inpatient, then PHP, then IOP. And that's just not appropriate developmentally because they're not the same. And so it's important to realize that we need these specialized youth treatment services. Integrated mental health services, so important. Most of the time adolescents are using it is to regulate some type of internal anxiety or depression or trauma. So there's a really big gap in this integrated service. What we tend to see is people are going to treatment for substance abuse, and then after they leave treatment, then they go to a mental health provider. And so it's not ever really kind of interwoven. So that's another gap. And transitioning adolescents from adolescent services to adult services and how those look different. There's really not anything to kind of bridge that gap. So it's also really important to kind of prepare adolescents on how they can be successful receiving services once they turn 18 and the demographic kind of changes. Next slide, please. This one's really big. Just cultural appropriateness with services. You know, it's like I said, they think they're bad kids. And that's because that's the cult, you know, the culture is to kind of scapegoat these adolescents in the family system and then of the court systems. I mean, it's really hard to empower somebody who feels that way. And so I think the language that we use is super important. And I don't think we have language tailored specifically enough to adolescents. And I feel like that's a big gap. We're super important. And then early interventions and prevention programs. I feel like a lot of the times, especially locally here, we kind of don't know what the other hand is doing. And so I feel like that becomes a big gap for someone to kind of fall through the cracks because there's not these connection types of brokering services to ensure that someone does successfully intake to whatever that next programming will be. And then of course, with the early interventions with the schools, I think what happens is when someone is found with substances on property, they typically are removed from the school and sent to a behavioral school. And that is not necessarily appropriate for treatment and for successful outcomes. Again, just reaffirming that stigmatizing language and those stigmatizing thoughts. And then family and community support. A lot of times I feel like treatment facilities working with adolescents don't understand how much work you're actually doing with the parents and how important that piece is. So having this more like inclusive programming can really be a gap. Next slide, please.
Sorry, we have about 4 minutes left. I know we're getting to recommendations, which is the part I know the subcommittee is really interested in, especially.
I'll go faster. Peer support networks is another gap. We don't really emphasize the importance of having that peer. It's not respected as much as traditional treatment modalities, and it's very, very important to have these kind of community-based initiatives. Continuum of care, very, very much important for someone who's an adolescent to sustain that long-term recovery. And then addressing these gaps, it requires that collaborative effort, you know, by policymakers, by healthcare providers, communities, families, advocates. So super important. Okay, next slide. So recommendations is education and awareness. Again, I think a lot of times people who are at the front lines with adolescents don't really know the language. They don't know the signs of addiction. They think it's behavioral things. They don't really necessarily know how to spot what addiction looks like among youth. And so I think developing and implementing these comprehensive prevention programs targeting various age groups could be very beneficial. Collaboration with schools, it's so difficult to collaborate with schools. It is, you know, there's not one person that you can talk to. You have to canvass for every single school, and none of the schools want to admit that their kids are struggling like this. And it's the energy it takes to canvass every single school and then to kind of get past that barrier of them thinking these are not our kids. Again, that stigmatizing language. And then organizing regular awareness campaigns in the community to promote healthy lifestyles so people can see what the recovery community looks like instead of seeing what people in addiction look like. Very important. Next slide, please. Access to treatment and support, always going to be important recommendation. Increased funding for resources that improve accessibility to affordable substance abuse treatment. I think right now for peer recovery support services, you can only receive 1 hour a week for Medicaid, and it's only $17. So I don't know anybody who's in their first 90 days of recovery that only needs one meet with a person. It just doesn't make sense. establishing partnership with local healthcare providers, promote and develop implementation of evidence-based practices that really does that holistic approach tailored to that individual. Next slide. Community engagement, fostering collaboration among community members, very important, law enforcement especially, and encouraging active participating in prevention initiatives, community watch programs, things like that, promote safety and supportive environments, establish a volunteer network, maybe provide membership, again, getting back to that peer recovery kind of network that people can really tap into, develop partnerships with local businesses, faith-based organizations, social services agencies, to kind of reduce stigma and provide easy ways of access. Next slide. Early intervention and screening, such a big part. Advocating for regular substance abuse screening programs in schools, healthcare facility, community centers. So really getting past those barriers to get into the schools and be able to screen for who are more at risk and prone to substance abuse, and collaborate with healthcare providers, really just increasing education about working with someone who has substance abuse. It should not be scary for providers and for treatment centers for working with adolescents with substance abuse. And education material, very, very important. We don't really have education material being taught to the schools, to the guidance counselors in the schools, to the teachers, to any school programming coaches. We definitely need more of that. And then next slide. Policy and advocacy. Like I was saying, $17 a week for 1 hour for PRSS services. We just have to do better. We need to be able to fund the services that are desperately needed, that are evidence-based, that are working. And I feel like we're taking too long to catch up. And by the time we're catching up, new evidence is coming out that there's something else that's more effective. And so we're always kind of behind the 8 ball with treatment. And so it could be pretty frustrating. And then last slide. And then again, I think data collection, very, very important. I think what I found is that most of the data that are being collected is really heavily based on stimulant use and opiate use. And that's really not appropriate for adolescents because although they might have experience using occasionally here and there, it's mostly based on alcohol, marijuana. And so we need better data collection to capture that information. And so it just needs to be more comprehensive, and there needs to be more sharing of data just across the board. So that is all I have. Thank you so much. I really appreciate this opportunity.
Thank you for your presentation, Ms. Chelly. Appreciate you being here and sharing such a robust presentation. I have a few questions, but wanted to turn it over to my committee members initially to see if there's any questions from folks.
Jessica, no questions for me, except that I appreciate that the presentation focused on all of the high notes and the benefits that go along with peer support services, and why we need to try to be pushing peer support services to be a more fundamental part of how we provide services to anybody who needs them, families, youth, and adults. So thank you for reminding us of all the reasons we should be doing this.
Thanks, Eric. Any questions from other subcommittee members?
Can I just make a comment? This is Debbie Nadler for the record. Araceli, thank you for that fabulous presentation. And it does show, it covers every aspect of everything that we need in this state. And I love how y'all touch on the families. It's so very important to bring the family disease, and nobody really focuses on that aspect. And I know y'all are doing so much. I can so vouch for everything that they do. Thank you. Thank you for helping our city, our state. Thank you.
Thank you.
Yeah, thank you, Ms. Nadler. I had a couple of questions. Malcolm, I see your hand is raised. Can we take your comment when we get to your presentation? Do you need to go?
No, I was just going to ask a question for her, but I can ask it later.
Okay, thank you. I had a couple of questions on my end. Many of the recommendations that were provided are slightly out of the scope of this particular committee, so I'm hopeful that staff will be able to share this presentation with the treatment and recovery subcommittee. Some of these recommendations may dovetail a little bit better with their priorities. So wanted to just make that recommendation out the jump. I was wondering, you mentioned the APG program, and it sounds like the model that's been developed is a little bit more intensive than other APG programs. I'm wondering if you have any evaluation data about the APG program as it exists in Clark County, sort of what that looks like and why you chose a more intensive model than other jurisdictions.
So the reason why we decided to go with a more robust model is because the population is slightly younger. So we know that the service that they need are more kind of in depth. And so a lot of the times when they are running these APG models, it's for the collegiate level. So it's for people who are 18 or 19. And although we do have 18, 19, and we go up to 24, we also have people who are 16, 13. And so we really need to be available for those adolescents who are limited on when they can get to services because of transportation. It's really not appropriate for a 13-year-old to take the bus. And so they're heavily reliant on parent transportation. And so we try to do a more all-encompassing approach, and we have found that to be successful.
Wonderful. And by successful, There Is No Hero in Huron, has TNHI done some evaluations of the alternative peer group as you've implemented it in Clark County?
Yes, one of the statistics I reported, the 30% sustained engagement over a year. That was something that specifically came from that. And if you just give me 2 seconds to pull up, unless Joe happens to have it on him, which I don't know if he does, if you have the community letter, Joe. Actually, I have it right here.
Yeah, I do not, but Jessica, I think you're asking about the surveys. It's anecdotal information at best, but it is a good benchmark for what our kids have experienced. So I think Ari just got it.
Yeah, so we send out, we believe in full transparency. So we send out a community letter quarterly, and 88% of our youth report feeling supported in their recovery. 82% said that their caregivers were educated. 81% said that they formed new recovery-based friendships. 76% of youth reported reduced substance use. 64% increased their school attendance. 52 reduced school missing assignments. 21 continued attendance for over 2 months, and then of course 30 for over a year. So we do these regularly and kind of see where we are at on top of the data collection we have in our electronic health records, as opposed which is more about demographics of individuals. So we know that there's a positive correlation between the services we're offering and youth in long-term recovery.
Thank you. I appreciate you sharing that.
Of course.
Many of the prevention and awareness and community engagement recommendations you cited are supported by the statewide coalition partnership, is my understanding. Is that a collaboration that that TNHI has explored?
I'm sorry, can you repeat that question again?
Yeah. The many of the recommendations that were shared under the community engagement and prevention and awareness are seem to be, from my understanding of presentations this committee's received in the past, sort of part of some of the purview of the statewide coalition partnership. So I'm just wondering if Tin High has had any collaboration with that particular group.
Jessica, what statewide coalitions are you speaking of?
Oh, so I think you mentioned at the outset that you received some funding from the PACT Coalition and other prevention coalitions across the state.
Understood. Okay, fair enough. Yeah, all right, fair enough. Yes, we have actually, well, our funding streams are going to expand in September 30th, and we have explored new opportunities, and we have a couple of grants written right now for the SUPTRS grant, I believe is specifically one of them, but no commitments on any other from any other funders. No.
Thank you. When you say substance use, does that include nicotine and tobacco for the teens that you see, for the young people that you see?
We do screen for nicotine and tobacco use. We do see adolescents for vaping who were caught for vaping prevention, vaping in their schools. Most of the time it's wax pens that they're vaping that we see more than we see nicotine and tobacco. So they could be included in the percentages, but it is a very small percent. The adolescents who get sent to us are usually people who, if they are vaping, it's marijuana.
Thank you. And then how did teens find the APG services?
So we do have that continued engagement, over 30% continue coming and feel supported in their recovery. And I believe the fact that they come to us when they use and they're scared, I think that we have done the most important thing that we could ever do, which is give unconditional love and support and acceptance. And so yeah, I'm very proud of what we do and how we feel about our services that we offer.
And also to add to that, we get referrals from the harbor, and we get the referrals from DJJS.
Oh yeah.
Great. Okay, so referral based primarily from other agencies?
Referral base, yeah,
Okay.
referral base and word of mouth.
Okay, wonderful. All right, so a teen themselves could self-refer into the program, or they could be referred by another agency in the community?
Correct.
Okay, terrific. Sorry if I missed that earlier. And then just my last question. I wanted to just ask if you're familiar at all with the Nevada Youth Risk Behavior Survey, the YRBS, a statewide biannual assessment of data that's produced by the University of Nevada, Reno.
I believe that's what, 2018, 2019? What's the latest date of that particular report?
I believe the last one was 2021. I think they collect an odd numbered years, so they should also be collecting data this year.
Oh, I've not witnessed that. I've not read the 2021, but yeah, I'm familiar with the previous versions of it.
Okay, terrific. I was just looking through some of the data recommendations and thought I wasn't sure if that source had been additionally reviewed. Thank you for your presentation today. Any other questions from the subcommittee members? All right, wonderful. Well, thank you, Ariane and Joe, for your presentation today. We really appreciate your time and answering our questions.
Thank you.
Thanks very much for the opportunity.
Thank you. With that, we're going to move on to agenda item number 5, which is a presentation on youth vaping. This was a recommendation that I put into the subcommittee on youth vaping prevention and had recommended Mr. Allo to present. So with that, I'll turn the floor over to Malcolm Allo.
Thank you, Chair Johnson. Thank you, Prevention Subcommittee. I am honored to speak with you all today. My name is Malcolm Allo, and I'm the Tobacco Control Coordinator at the Southern Nevada Health District in the Office of Chronic Disease Prevention Health Promotion. I know that's a very long office, but I'm speaking on behalf of them, and I'm also speaking on behalf of the Nevada Tobacco Control and Smoke-Free Coalition, where I serve as president. The Nevada Tobacco Control and Smoke-Free Coalition is a organization of over 40 different groups, health district, nonprofits, academia, hospitals, etc., that all work together to reduce the burden of tobacco use in our state. So I'm actually representing 2 groups, Southern Nevada Health District and NTCSC. Next slide, please. I have no disclosures. So currently we are in a vaping epidemic. 1 in 6 Nevada teens use electronic vaping products, and that should alarm anyone. This is important because we know that tobacco is the #1 cause of preventable illness of death in the United States. Annually, over 480,000 people would die from tobacco-related illnesses and death. This is more than alcohol, car accidents, illegal drugs, murders, suicides, and AIDS combined. And that fact has not changed since 1999. So I just wanted to reiterate that tobacco use is still the leading cause of preventable death, even though traditional tobacco, commercial tobacco use have declined. You'll see here in my next couple of slides that the emergence of electronic vapors has increased, still resulting or adding to this death count. The use of electronic vaping products or electronic cigarettes often leads to co-use or commercial tobacco use. And the last bullet here is prevention is key. We know through data that 90% of adult smokers started before the age of 18. So it is of utmost importance that us in prevention prevent teens from starting. And if we do so, then we'll prevent them from a lifelong addiction on tobacco use and nicotine. Next slide, please. Using the YRBS, like Chair Johnson had mentioned, here are the current rates of our Nevada youth vaping prevalence. The first rate is 36.7%, and these are for all high schoolers who have tried using electronic vaping products. So that's almost 40% of Nevada teens have tried using electronic vaping products, and that's scary. Even more scary is the next bullet, which is 12.6% of all middle schoolers have tried using electronic vaping products. And past 30-day users, so this is what we consider current users of electronic vaping products. 17.6% of high schoolers are current electronic use vapor users. And again, just as alarming is our middle school rate at 13.4%. And I just want to remind the group that middle schoolers, for those of you who are not that familiar, are 11-year-olds, 12-year-olds, and 13-year-olds is what we count as middle schoolers. So 13% of them are using electronic vapor products on a daily occurrence. The bubbles below on the chart, you'll see our work or our progress to date from 2019 to 2021. 41.7% use electronic vaping products ever, like just tried in 2019. And we see a positive decrease or a trend in the right direction down to 36.7% over the last 2 years. The bullet below that, 18.7% to 12.6% is the number of middle schoolers that tried it. So we also see a positive decrease or a trend in the right direction of middle schoolers have ever tried it. Current users of electronic vaping products, you can see that number was 21.9% or almost 22% in 2019, and we got that number down to 17.6%. So again, positive direction. However, here is where we are having an alarming issue is our middle school rates of current users went from 8% to 13.4%. So we see the trend going in the opposite direction. I just want to note here that when we compare electronic vapor use to combustible commercial tobacco use, so traditional old-fashioned cigarettes, our smoking rate is below 3%. And when you compare it to 3% for high schoolers, and when you compare it to high school electronic vaping rates, that's 17.6%. So you can kind of see here where the substance use when it comes to smoking lies, and that is with electronic vaping product use. Next slide, please. Here is the issue, is that youth vaping prevention funding here in Nevada was eliminated. So currently there is no youth vaping prevention funding or funding to address youth vaping here in our state. Here are estimates from the 2019 session. Over $231 million comes into the state of Nevada as a result from cigarette taxes, other tobacco taxes, and settlement funding. And I just want to reiterate that number, $231 million comes into our state as a result from tobacco use or vaping. And if you break down that number, here's how it breaks down. 145.2 million of that comes in from cigarette taxes. 0% is allocated for tobacco control and prevention. 30.8 million comes in from other tobacco taxes. So these are taxes on electronic vaping products, the thing that we're talking about today. However, 0% or $0 is allocated for tobacco control and prevention. Just recently, our Attorney General's office won a settlement, a Juul settlement for deceptive marketing practices against Juul, and that resulted in Nevada receiving $14.6 million. And for those of you who are unaware, Juul is an electronic vaping product. However, 0% or $0 of that settlement is going to tobacco control and prevention. And every year since 1999, Nevada receives a tobacco master settlement funding. And this is the funding that was a result from when the tobacco industries lost their big lawsuit 25 years ago. We receive about $40 million annually. And only $950,000 of that goes to tobacco control and prevention. And that number is decreasing every year. So if you add up all of the amount of money that we receive as a result of tobacco and all of the money we get for tobacco control and prevention, this equates to 0.004% of Nevada's money that goes to tobacco control and prevention. Strikingly, the CDC recommends that we in Nevada spend up over $30 million in tobacco control and prevention. So you can see we're far from there. And this ranks Nevada as 47th in the country when it comes to tobacco control and prevention funding. So we're very, very at the bottom. The two states that are below us are tobacco producing states. So just to give you an idea on where Nevada falls in when it talks to prevention funding for youth vaping. Next slide, please. Our populations, when we talk about youth vaping prevention funding being eliminated, this will affect our youth priority populations. When we look at the YRBS, we know what youth are using using these products. That is African Americans, Hispanic, Latinx, LGBTQ+, Native Hawaiian Pacific Islanders, low income and low SES, socioeconomic status youth. And if we dig even deeper, we know that those specific types of youth within those priority populations are teens, 13 to 18 years old, who play or participate in sports, or athletic teens that are no longer receiving education or outreach services about youth vaping in Nevada. Next slide, please. So what's working well? Evidence-based programs. The CDC has outlined 4 goals that all tobacco control and prevention programs should work towards. And these 4 goals are to prevent tobacco use initiation among youth and young adults, promote quitting among youth and young adults, eliminate exposure to secondhand smoke, and identify and eliminate tobacco-related disparities. And we here in Nevada try our hardest to do that with the limited amount of funding we get. Again, it's $950,000 statewide. So all partners, all health districts gets a part of that money. So it's not like Southern Nevada Health District gets $950,000. All statewide partners have to fight or compete for a part of that money. Within those 4 goals, here are the 4 activities that the CDC recommends that we do, and we have done when we receive tobacco vaping funding from the state before. And these activities are state and community interventions, mass reach health communications, cessation intervention, and surveillance and evaluation. Together with these activities and those 4 goals, the CDC and we believe that these strategies does reduce tobacco-related disease, disability, and death. Next slide, please. Our gap simply is that there is no youth vaping prevention funding here in Nevada, not anymore. For the last 4 years, our state legislature has approved and funded youth vaping prevention funds, $2.5 million per year. However, during this last legislative session in 2023, those funds were eliminated. And our second gap would be the lack of resources to continue education, surveillance, mass media campaigns, etc., towards youth to get them not addicted to to nicotine and tobacco use. Next slide, please. Our recommendations is pretty simple. Our recommendation would be to allocate or prioritize tobacco control and prevention funding with tobacco settlement or tobacco tax dollars. Like I outlined in my previous slide, over $200 million is received in Nevada as a result of tobacco tax, but we receive 0.004%. So we would just like to see that percentage increase. The Nevada Tobacco Control and Smoke-Free Coalition recommends $2 per capita in Nevada dedicated to tobacco control and prevention efforts. This would total $6.2 million annually. And if we just do this simple step, again, 6.2 million of the 240 million that Nevada gets, it would move Nevada from being ranked 47th to actually right in the middle of the pack. So we'd be ranked number 24th in the country just by increasing our funding from to $6.2 million per year. And then allocate the funding that we receive using the local lead agency model, which would be allocating it to the Southern Nevada Health District, the Washoe County Health District, Carson City Health and Human Services, and the statewide partnership, which will reach the rural coalitions. Next slide, please. And here are my references where you can check my facts and see my data. And I think that's it. Next slide. And that's my contact information. Happy to answer any questions.
Wonderful. Thank you so much for a robust presentation, Malcolm. I really appreciate you being here. I have a couple of questions on my end, but wanted to turn it over to my subcommittee members to see if there are any initial questions from the subcommittee.
I have one. Debbie Nadler for the record.
Go ahead, Debbie.
Thank you so much for the presentation. I do have a couple questions to ask you, and I wrote them down. I'm so sorry. So from my understanding, and you're the expert, I'm not, but from what I'm hearing, a lot of the vaping is marijuana. Do you have any numbers on the breakdown of what is tobacco and what is marijuana? That's number one. And then number two, because smoking is smoking and smoking marijuana and smoking tobacco, didn't we have, I thought our marijuana industry put aside a ton of dollars that were supposed to go to education, and quite honestly, I can't seem to track that or follow that. And you know, I agree, absolutely, we should do something about the smoking, but these kids that are 12 years old and 13 years old are smoking pot.
Right.
And that's a big thing. I mean, it's legalized in our state. So, you know, when kids at that young of an age see something like pot legalized, like, hey, my parents are doing it, everybody's doing it, there's ads, there's billboards, it's cool. If it's safe for them, it's safe for me. And plus, not to dispute anything that you said at all, but the lawsuit money has to do with opiates, has to do with what the Sacklers and the pharmaceutical companies and everything. My son died. He never smoked cigarettes in his life. And I know a lot of others didn't either. And I do appreciate the efforts to stop smoking, but I'm sorry, I personally don't see our lawsuit money being put towards this. That's just my opinion. Thank you.
A point of chair privilege before you answer those questions, Mr. Allo. Ms. Nadler, thanks for your questions. I just wanted to remind the folks on this committee that the SURG is really charged with addressing broadly all substances. And I was hoping Mr. Allo could also talk about, there's two different settlement agreements. So there's the ones that are happening presently with the Attorney General, and then there's a tobacco master settlement agreement. I believe you were speaking about those dollars previously, but could clarify. Apologies, and go ahead and answer the questions, Mr. Allo.
No problem. Thank you, Chair Johnson. Okay, I think the first question was, well, what are youth smoking? I tried to write them down, Mr. Nadler, as you were speaking. So when we use data looking at the YRBS in 2021, we can tell what types of substance that teens are using, and the substance that teens are using at the highest levels are nicotine, tobacco, followed next by marijuana or cannabis. So what our fear is that a lot of teens who are using electronic vaping products are dual using, meaning they're using both. So when we are talking to administrators or teachers in high schools, what we're finding, and we are actually in all 32 comprehensive high schools here in the Clark County School District, we're finding that teens are being caught more for nicotine, tobacco, instead, like when they get caught with their products on campuses, in comparison to wax pens or cannabis. That's what they're confiscating from teens in the high schools. So, and the data from the YRBS supports that. So I agree with you, the legalization of cannabis in our state has made social acceptance of cannabis use, and therefore it might result in an increase in cannabis amongst our teens. We're just not seeing that yet. Here in our state. Where we're seeing the explosion is the nicotine and tobacco use with electronic vaping products. The second question I think you mentioned was the dual settlement funding. Nevada won the dual settlement funding for deceptive marketing practices for the Juul product, which is the electronic vaping product, marketing illegally to teens nationwide. So that was what that lawsuit was. So it was 14.6 million over 5 years that Nevada will get split up. So we get like 3 million or something a year. 14.6 million over the course of 5 years. So did I miss another question?
No, that's perfect. Thank you. Thank you for that information. I've just seen so many kids smoking marijuana. It's ridiculous. I mean,
It is.
you could smell it everywhere you go, and we're not addressing that either. But
I'm
now that
happy
you're
to come
bringing up
back and do
smoking.
I'm happy to come back and do a presentation on cannabis in the high schools, because what we're seeing the problem in high, and I'm going to deviate real quick, Chair Johnson, is edibles. Edibles in the high schools is the problem, because what happens is teens are taking edibles in first period. By third period, they're not feeling an effect. They're taking a second edible, and then they have a delayed onset, and then they end up in the hospital. So edibles is really an issue that teens are using when it comes to cannabis use. So.
And you know what? That's what I was seeing that too. When I say marijuana, I mean edibles too, because I'm not real good on all that. But if we could have him come back for the marijuana and the edibles, that would be great. Thank you so much. Thank you.
Thank you.
Well, it looks like our September agenda is coming together. Mr. Schoen, did you have any questions for Mr. Allo?
No, I thought Ms. Nadler covered that well. So thank you.
Wonderful. I have just a couple of questions on my end. I was wondering if you could, perhaps you know about this, Malcolm, or the subcommittee could follow up. Do you know anything about how the Juul settlement is getting dispersed presently in the state of Nevada?
Absolutely. So the Juul settlement, because the Juul settlement was a blanket award, meaning that the award did not specify specifically what it needed to be used for, unlike the opioid settlements, meaning they just won the lawsuit and the lawsuit was turned over to the state. The state, therefore, can use it however they want. So our current Juul settlement fund is now being allocated to Nevada Legal Aid, the entire amount. So if the award or if the lawsuit settlement stated that this money had to go to tobacco prevention and control, then by default, the AG's office would have to allocate that money to tobacco prevention and control.
Thank you. I was wondering if you could share a little bit more about the statewide vaping campaigns from the funding that was eliminated. Do you have any outcome data available, or any of the other projects that were stood up as a result of that you could share with the subcommittee?
Yeah, absolutely. So as a result of the statewide media funds that we received for the last 4 years, again, we got 2.5 million per year for the last 4 years. And in this session, we did not get refunded. And moving forward, we were able to move all of those prevalence numbers down, as you saw from the ever tried and the current users, except for middle school. And this is why we know that our work was effective, or we believe our work was effective, was that all of our interventions happened at the high school level. However, we did not do any interventions at the middle school level, where we know the onset of the electronic vaping product starts. Therefore, you can see in that chart with the bullets, you could see that was where the trend actually went the opposite direction. It was because there was no intervention, no education, no outreach, or any strategies there to prevent those teens from using these products. So we were able to, like I mentioned, attend 32 different high schools. We were in the high schools 4 times a year. We did curriculum development, policy passages, et cetera, to just change the culture and increase the education amongst these teens, resulting in a downward trend in prevalence. What we're afraid of is that without any youth vaping prevention funding in our state, that those trends are going to reverse and increase. I actually have one more thing, Chair Johnson, that Ms. Nadler said that I did not address, was the cannabis industry did allocate money for education. However, none of that went to prevention. So we did not receive any money from the cannabis industry to do any types of prevention, whether that's cannabis prevention or electronic vaping product prevention. So we do not receive any of those money.
Thank you. I was just going to ask that. Thank you. Yeah. And I feel like we should have, or y'all should have, but
something. Yeah.
That's just my point. And thank you also for reiterating that fact. And you're right. I went to a lot of the high school vaping programs. My niece kept inviting me to, and other students to their schools to hear them. You're right. They were all in high schools, and I never did see any in middle schools. And perhaps that might make the difference, the middle school part of it. You did bring up a very good point. Thank you.
Thank you.
Wonderful. Any other questions for Mr. Allo? All right, hearing none. Thank you so much for your presentation today and answering the questions of the subcommittee. It sounds like we'll be discussing inviting you back to talk more about the questions around cannabis and marijuana.
Thank you very much. I appreciate it.
Thank you. Wonderful. Let's move on to agenda item number 6, which is the Prevention Subcommittee recommendations for review and discussion. I'll turn this over to Emma Rodriguez to detail out just a little bit of the recommendation process from the SURG committee.
Thanks. Emma Rodriguez for the record. So, so far we've had 6 recommendations submitted by Prevention Subcommittee members in 2023. Those were all reviewed during our June meeting. And as you may recall, we further workshopped these into 3 recommendations and incorporated some into the harm reduction recommendations during that June meeting. And the following slide will list what those 3 recommendations are. And then at last week's SURG meeting with the entire working group, we received feedback from other members. And if you want to take a look at all of the information for what had been submitted, that has been posted online from the June prevention meeting. There's a screenshot on the slide that includes all of the justification and background information. So this right here, these are the 3 recommendations as of June. And Chair, I'm not sure if you want to go through what was discussed at last week's meeting. Oops.
Yeah, I'd be happy to do that if that's all right.
Great. Let me go back to the slide. All right.
Terrific. So had the opportunity to present on our work, which thank you to the committee for that opportunity. With regard to number 1, we received comments from Dr. Stephanie Woodard noting that it is important for us to understand how these funds come into the state and how they're distributed. So a summary of kind of her feedback was that there would be some concern about shifting dollars from treatment to prevention. So based on that feedback, it feels like it would be important for the subcommittee to reach out to Dr. Woodard or who oversees this type of collaboration work at the state to learn a little bit more about the funding streams and how we might potentially further workshop this recommendation to be a little bit more specific. Thoughts from the subcommittee on that strategy, or go ahead, Mr. Schoen.
Thank you. I appreciate you summarizing that feedback. My immediate response is that we were not recommending that scarce treatment dollars be pulled from treatment. So it's not, in my mind, this isn't a zero-sum game. We're really, and this was quite intentional on our part. I mean, double is a pretty ambitious goal, but it's really to highlight that we need to be thinking about how we can raise, if we have the goal of reducing significantly the impact of mitigating the harm of substance use, then these are the kinds of things we need to invest in. And so we aren't making the recommendation that we pull. Heck no, did I ever think that that would be the idea? What I was hoping this would do would create a conversation about, just as we need to invest in roads, and so we'll find a way to either raise taxes, I hate to say it because that's a dirty word around here, but we would find a way to increase public investment in something, in my mind, that's as essential as having good public transportation, is having good substance prevention and treatment, but not cannibalizing one at the expense of the other. That makes sense.
Thank you, Mr. Schoen. That does make sense. And I made a little bit of that point that the goal was not to take one amount from the other, but to perhaps there was a gap in our knowledge about sort of what presently existed funding wise. And maybe if we could learn more about what that looked like, that we could help identify additional sources or resources to help scale this up and potentially further workshop the recommendation.
May I respond?
Yeah.
So I think you're right. I mean, given the time we've had, that's been outside our purview to be, outside our ability to really get into that. But I still like this recommendation. I think it has important symbolic value. I think it's a little bit uncomfortable, which is what I like about it, because it really does force us to look at it. And in the coming year, I agree with you. That could be a part of our, if we really want to dive into this, we could ask for some presentations and really get into the weeds of what that funding looks like. I still think, I mean, regardless of that, I don't think I need to understand the funding to realize that we have scarce, we have a very small amount of the resources that we actually need to make the kind of dent that we need to in this. So whether it's, 5 different federal grants that make up the funding and a little bit of state funding, makes no never mind to me. The important thing is that we just don't have enough. We need more investment in this period and we have to rethink how we're providing what part of this and we have to, I think, underline the importance of primary prevention in the overall scope of making a difference with this.
Thank you.
Jessica,
Go ahead, Ms. Nadler.
Sorry, I don't have the hand raised. This is Debbie Nadler for the record. I agree with Eric 1000%. I mean, our whole thing was prevention, and primary prevention. It is lacking. I mean, if we had it, and if we had enough of it, we wouldn't be losing more and more kids every day, and younger kids. What was used in the past and what has been used is not applicable to today's society and what's happening with our youth. When we have kids starting to use at 11 years of age, perhaps maybe an idea would be to bring Dr. Woodard here to tell us what is being done and how the money is being used. And I know personally, just calling Clark County, the CCSD, Clark County District, everything that they're doing in Washoe County, I never can say it right, excuse me, is not what we're doing here. If you look at their prevention and primary prevention up north, they're doing a lot more than we are down south. So I don't know if that number is coming from what they're doing in the north as far as primary prevention and not being applied to what's happening here. But I know personally from calling schools, the kids do not have ID cards that have an emergency number on the back of them, mental health, substance use, any kind of phone number on the back. And Dr. Woodward said they did, and they don't here in Las Vegas, not all the schools. They do not. And as far as primary prevention programs, there's really not any down here. I've called schools for 4 years. And sorry, I'm so passionate about this. And I absolutely agree with Eric 1,000,000%. We have got to focus on these kids. We've got to stop them before they start. I was in a group, and I will stop with this. I was in a parent group, Las Vegas Parents of Henderson in Las Vegas. There's 65,000 people in that group. Somebody talked about drugs the other day, and I just happened to make a comment about please be careful what you let your kids take. It led to a big discussion. And I can't tell you how many moms in there said, not my child, no way, it's your fault your son died, it's the parents' fault. I mean, it was amazing, the stigma that came out of this group. And it's why it's needed. The parents don't know, the kids don't know, and we're going to keep losing kids without warnings, without prevention. It's so important. Sorry. That's it.
Thank you for sharing your story, Ms. Nadler, and I'm sorry that happened to you. I agree that there is continued investment needed for all of the reasons that you and Mr. Schoen stated. I think it would be helpful to understand sort of the baseline of what is currently available. I also, in my reading of the state plan, it doesn't seem like there's a specific area that looks at primary prevention. Perhaps I missed it, so I don't. I'm happy to go back and look at that a little bit more closely, and how that in the Fund for Resilient Nevada projects coming out, if there are areas for primary prevention applications, could be additional opportunities that are identified to increase this investment. So I'm going to recommend that we follow up to learn a little bit more about the funding streams that exist. And then at our September, is that right, Ms. Rodriguez, subcommittee meeting, perhaps we'll entertain some additional workshopping of this recommendation. Thanks. With
Thank you,
that,
Jill.
I'm going to move on to number 2, if that's all right. For the subcommittee, we presented around increasing support for youth vaping prevention as an initial recommendation, but we're awaiting Mr. Allo's presentation today. So in the interest of time, I am hopeful that if there were any recommendations, specific ones that Mr. Allo presented today that we'd like to amend recommendation number 2 or workshop for September, that that's submitted through the link that Ms. Rodriguez provided. I have a few ideas, but would love to hear if others have them as well. Maybe we could send in all of our ideas, Ms. Rodriguez, from Malcolm's presentation.
Jessica, Debbie Nadler for the record. Is this the one where we could add the marijuana and the gummies and different things to the number 2?
So that is likely a separate recommendation because this one is specific to youth vaping. So 2 ideas. One, could complete that as an additional recommendation and identify someone who could speak on that at our upcoming meeting. Or I think agenda item number 8 considers additional folks who might be able to speak at an upcoming meeting. So two strategies.
Thank you.
And then recommendation item number 3 around the alcohol outlet density report. We didn't receive much feedback on this at the July meeting from anyone. So except I think Chair Ford indicated that he was also interested in this data. So we are going to receive guidance at our September meeting about weighting and finalizing the recommendations. So how the subcommittee will do that, or maybe in advance of our September meeting, from Ms. Rodriguez. Any other discussion item on these recommendations?
Yeah, Chair Johnson, Eric Schoen for the record. One of the questions we had, and maybe it was asked at the last meeting that I was unable to attend the July meeting, or earlier July, of the entire SURG committee, whether or not we could continue to highlight those recommendations made last year that we thought still were important to attend to. Did we receive any feedback on that?
We did. Ms. Rodriguez, do you recall the directive for that?
Yes, Emma Rodriguez for the record. There was discussion about that, and Chair Johnson spoke on your behalf, Vice Chair Schoen, just kind of making the case for what you had pointed out about the need to revisit the annual report. And Dr. Kearns spoke about that too, about how it came up in other subcommittees, and the SURG decided that they should be revisited. So that will be included in the guidance that we'll be sending out in advance of the September meeting. I'm not sure if it'll be a survey, or we just need to think through, since these meetings are usually only an hour and a half, if we're going to have presentations and scoring, seeing what pre-work can be done in advance. So we just need a little bit of time to think through all that. And if you have any recommendations, I know the SCI team would be interested to hear if you think that there's a particular way to go about that.
I will think about that.
I just think an important part will be determining what progress has been made on any of the recommendations. And I think that's where SCI will need the help of the subcommittee members to help determine you know, what you as the subject matter experts have seen. So maybe that will be a question on the survey.
So for the record, Eric Schoen, I was actually thinking something much simpler, because oftentimes for a lot of these long range goals, year one's, just sort of barely perceptible progress. If any, you're sort of marshaling people's attention and starting to get the resources moving. I was thinking something much simpler if we wanted to. It could even be binary, simply yes or no. I mean, of asking us as members, would you like this goal to be continued on to the next for the 2023 recommendations? And maybe if we had a quorum of folks who said yes, then that recommendation would get passed through, something like that. It would be interesting to see what people said. Do you feel like if progress has been made? What are you seeing has been, what kind of progress? But I would fully expect many of those to not be much further than they were 9 months ago.
Thank you. Hopefully that's helpful guidance, Ms. Rodriguez, as you pull that together, and thank you for your question. If there's no additional discussion on agenda item number 6, I'm hoping to move on to agenda item number 7, where we did receive quite a bit of additional feedback on the harm reduction recommendations for review and discussion.
Chair Johnson, just really quickly, thank you so much for bringing up my concern to the larger committee. I appreciate it.
You're welcome. I did my best in your stead, but definitely.
Sure, you did great.
Thank you. So Emma, did you want to review this quickly for folks?
Sure, Emma Rodriguez for the record. So as you'll all recall, we had following the April harm reduction meeting with the full SURG, we distributed a survey to get feedback from folks on the recommendations that were presented by the subject matter experts. This subcommittee then met in June and discussed those survey responses alongside the recommendations that were workshopped at the meeting last week with the full SURG. Chair Johnson reported out those recommendations and we received feedback on some of them. And on the following slides, there are the 6 recommendations that are in the form that they were in from June. And I just wanted to note that one of the recommendations, which was on alternative pain treatment, was sent to the treatment and recovery subcommittee. So that is not included on the slides.
Thank you. So we didn't receive much feedback from the SURG for the first 4 recommendations, but the legislators on our committee have not seen these yet. So perhaps at the next September subcommittee meeting or in the interim, they may have additional feedback on these particular recommendations. Recommendation number 5, Dr. Kearns shared some model legislation that can be referenced to enhance recommendation number 5. Ms. Rodriguez, was it your understanding that our subcommittee would be making those changes on behalf of the full SURG?
Emma Rodriguez for the record. I was reviewing the draft minutes this morning that Laura Hale had started, and because I didn't recall what the decision was and it doesn't seem clear. So I know SCI will be meeting with the AG and DHHS staff in the coming weeks. And so I think we'll try to get some sort of recommended guidance that will then be presented back to determine what the plan is. I don't know. I think Dr. Kearns is on the line if she might have a different answer, but again, I think we'd take all the subcommittees members' thoughts into consideration if you have any particular way you'd like to go about it.
Okay, thank you. I'd be interested in the outcome of those discussions, just wanting to ensure that the prevention subcommittee is allocated the time to do this on behalf of the full SURG, in addition to our other charges around more primary prevention efforts.
And on that note, if I may ask one quick question, Chair. Thank you, Emma Rodriguez for the record. I'm curious if we do need to add an additional meeting or time to go through the harm recommendation weighting. Would subcommittee members prefer a longer September meeting, or is it preferable to have an additional meeting? So the question is 2 shorter meetings or 1 longer meeting?
Debbie Nadler for the record. Personally, I would prefer 2 shorter meetings, but I'm flexible, whatever everybody else wants.
For the record, Eric Schoen, that would be my preference as well.
Chair Johnson, same with the Debbie and Eric. Thanks for asking, Emma. And then for recommendation number 6, it was noted that there's a lot of interest at the national level around the CHWs, and Nevada has been a leader in this. And it was also noted that the state had done some crosswalking around opportunities for cross certification between community health workers and peer recovery support specialists, and that had recommended Sean O'Donnell from Foundation for Recovery to talk a little bit more about that intersection. And following the meeting, I was shared just some additional information about what's been received so far around the overlap between peers and CHWs, which I would be happy to share with the subcommittee members and post on the website. What is the committee's thoughts on hearing a presentation or requesting a presentation from Mr. O'Donnell on this?
For the record, Eric Schoen, I think that'd be a good idea.
Terrific, thank you.
Debbie Nadler, yep, I do too.
Okay, wonderful. So we can move forward with that as we move to agenda item 8. That's where the harm reduction recommendations stand. And with that, we'll move on to agenda item number 8. So we'll consider subject matter experts and topics for future meetings. Based on the July 12th SURG meeting, we've discussed a presentation on funding for primary prevention, a presentation from Sean O'Donnell from the Foundation for Recovery on the intersection of peers and CHWs. And then a presentation from Mr. Allo, potentially, as we discussed today, around cannabis and marijuana programming, funding, etc. There was also discussion about Mercer to discuss the scoring tool that we might be using for prioritization of these recommendations. And open to anything else from the committee. I guess if there are additional recommendations that come in, we could suggest additional presenters.
Debbie Nadler for the record. I sent something, and maybe I didn't, but I thought I did, on DARE. They're using it up north. Could we possibly have somebody? It's already being used, the DARE program. It's been restructured, and it's for all ages.
Thanks for your question, Ms. Nadler. I believe we talked about that at our June or maybe July subcommittee meeting. At our June subcommittee meeting. July. Ms. Rodriguez, do you recall?
This is the July subcommittee meeting. I believe it was in June or May.
Thank you. Thank you. It's all running together for me. And had opted, rather than to discuss presentations from really individual programs, to really look at standing up primary prevention, and that recommendation number 1 was where we had moved a lot of those specific programming pieces towards, so that we could instead robustly support programs statewide and allow for kind of individual communities, counties, cities, school districts, coalitions, etc., to determine, implementation on that front. So my recommendation would be to hear a little bit more about the funding, Ms. Nadler, if possible, so we could understand more about how to scale that up.
Okay, I understand. Just for future references, I'm just wondering, do they need us to break down number 1 more specifically for specific things? And that's what we'll do after we find out the funding. specifics for under one. We're just kind of putting a general thing on here, primary prevention 0 through 24. Perhaps if they saw specifics on what is really needed, would that help? Broken down, like DARE, the DEA, or the different programmings that are being used and that are evidence-based.
Yeah, just referencing the guidance we received last year around kind of recommendations for specific programming versus more kind of statewide strategies or broad implementation. I think if there were potentially specific subjects or areas of emphasis for the primary prevention dollars, that could be listed. I would be not in favor of listing specific programs because I would want that to be determined at the local level based on the local conditions.
Gotcha. Thank you.
Yeah, Mr. Schoen, do you have any additional thoughts on that?
I do not.
Terrific. It sounds like we have a very robust agenda for the September meeting. And Ms. Rodriguez, it sounds like we received additional guidance around recommendations for a second meeting rather than a longer than 90-minute meeting. Wonderful. All right. Noticing the time, I'm going to move on to agenda item number 9, which is our second period of public comment. Ms. Rodriguez, do we need to read these again?
I don't
NRS?
believe we need to read it again, but I'll have the dog correct me if I'm wrong.
No, you don't.
Okay, great. Thank you so much. All
Perfect.
right, I'm not seeing any hands raised or any sort of indication that anybody would like to provide public comment at this time.
I do have one item for public comment, if appropriate. This is Jessica Johnson. I wanted to mention that there will be the Southern Nevada Substance Misuse and Overdose Prevention Summit happening at the Red Rock Casino in Clark County on August 10th from 8 to 5 p.m. A really robust showcase of projects and programs happening in Clark County and really across the state. Coupled with that will be a SHIELD training that will focus on training law enforcement and first responders around additional strategies for naloxone and how to stay safe as they respond in communities for substance use and overdose. So if there's any additional questions or anyone is interested in learning more, you can reach out to Katarina Pulver at PULVER@snhd.org. Ms. Rodriguez, anyone else for public comment?
No, I do not see anybody.
Can I just say one thing? Debbie Nutler for the record, Jessica Johnson, I just want to applaud you for your presentation during the SURG committee. You nailed it. You were unbelievable. It was awesome. Thank you. Thank you for representing us.
That means a lot to me, Debbie. Thank you so much for saying that. It was definitely an honor, and I felt very well prepared as a result of this subcommittee and the excellent coordination from the SEI team. So thank you for that. With that, we'll close our period of public comment and move on to agenda item number 10, which is adjournment. And we're 1 minute past the hour. Thank you all so much for your robust discussion and for the excellent presentations we received today. Really grateful to you all, and we'll talk again soon. Take care.
All right. Take care, everybody.
Thank you. Take care.